Welcome to Savitha Dental College Lecturecast, Oral Maxillofacial Surgery, Cyst of Maxillofacial Region, Part 2. Treatment for cyst or enucleation, mospitalization followed by enucleation known as Waldron's procedure, and resection. So mospitalization or parchment or cystotomy. So we put an incision, elevate the mucoperiosteal flap, create a window, and remove the content of the cystic cavity and part of lining. There is no complete removal of the lining in mospitalization. In enucleation, we put an incision, elevate the mucoperiosteal flap, create a window, remove the entire lining and the content. Periapical cyst is most common cyst. So the involved tooth we can go with RCT and periapical surgery. In that we do enucleation and episectomy and retrograde filling. If tooth can't be saved, it has to go for extraction. Residual periapical cyst is nothing but when the tooth has been extracted, leaving behind the cyst that is known as residual periapical cyst. Treatment is enucleation. Dentigerous cyst is the second most common odontogenic cyst. It occurs around the impacted tooth. So it's mostly common in young adult, and most common sites are mandibular third molar region and maxillary canine region. There's a fluid accumulation between the reduced enamel epithelium and crown of the tooth, and its enlarges gives rise to dentigerous cyst. Radiographically, we can see a radiolucent lesion encircling the impacted tooth. On aspiration, it shows a stockler fluid. Treatment for dentigerous cyst is enucleation with removal of the unerupted tooth or impacted tooth, and we can go with mospitalization also. Untreated dentigerous cyst can lead to ameloblastoma. Primordial keratocyst or keratocystic odontogenic tumor is derived from cell traits of dental lamina. It is benign but locally aggressive developmental odontogenic cyst. And it is more common in ramus and third molar regions, similar like dentigerous cyst, and more common in mandible than maxilla, about 5:1 ratio. And it's more recurrent than any other cyst, it's about 33%, because of thin fragile lining, an high mitotic index epithelial remnant, and presence of satellite or daughter cyst. Patient will come at late stage with the expansion of the bone. Radiographically, it shows a multiloculated or uniloculated lesion. This X-ray shows about a multiloculated lesion from your incisor to up to the condyle. Coming to treatment part of OKC, we go with enucleation. Additionally, we apply coronoid cryoelectrode. Trimming the bone has to be done because to avoid recurrence. Because by doing these things, we eliminate any remnant lining as well as we destroy the daughter or a satellite cyst. Recurrent cases, we go with hemisection or partial resection of the bone. Mospitalization is contraindicated. This picture shows enucleation of the lining with removal of the keratin content of the cyst. Non-odontogenic cyst. Globomaxillary cyst, which occurs between the lateral and canine region maxilla, and median palatal cyst at the mid of the palate maxilla, and nasopalatal cyst at the junction of your nasal and the palatal area is seen, and median mandibular cyst at the junction of your right and left mandible part. Pseudocyst or cyst without epithelial lining, like solitary bone cyst or traumatic bone cyst, is similarly like soft tissue contusion. So any trauma to the bone, there is a contusion of the bone. As it dissolves, leaves an empty cavity that is called a solitary bone cyst. On aspiration, it is negative, and we can a classical appearance of a scalpel appearance, loss of lamina dura is seen in the radiographic. Aneurysmal bone cyst, any vascular lesion within the bone which resolves and leaves an empty space is called as aneurysmal bone cyst. So both solitary or aneurysmal bone cyst, there's no specific treatment, we can leave it, but there are chance of any metastatic lesions or metastatic malignancies in the mandible. So we go with a surgical exploration and rule out any other lesions. Staph bone cyst has a classical ovoid appearance below the inferior alveolar nerve, the third molar region. This is because of inclusion of salivary gland. So we can go with ciliography and confirm a diagnosis, that is a Staph cyst, and routine follow-up is more than enough for the Staph cyst. Thank you.